Uh, Today we are going to talk about PrEP for trans women. What are the opportunities and challenges? And both JoAnne and Madeline are well-known activists in this field, and the only thing I can say is that this is an extremely important topic at this time, because we more and more efforts are starting to focus on trans women and the potential role of PrEP there, and unfortunately too little has been said about PrEP and trans women so far. This is in fact one of the first presentations focusing on PrEP and trans women, so we hope it's going to be very important to many of you. And we really hope it's going to contribute to the discussion. We know all the discussions are coming. We know as well that some publications are going to come, but I mean, PrEP has been a difficult topic in general, and it has been particularly difficult for transgender people. So now I'll just, I think we have, okay, let me check.
So, well, good morning or good afternoon, everyone, wherever you may be. My name is JoAnne Keatley. I'm the director, co-principal investigator at the Center of Excellence for Transgender Health. And this morning we're presenting PrEP for trans women. What are the opportunities and challenges? It's a pleasure to be with you this morning. And I cannot move my slides forward. Carlos or Pedro? Someone needs to give me control of my slides. Okay, thank you. All right, so we are the Center of Excellence for Transgender Health, and this picture that you have in front of you is actually it's a picture of our staff and colleagues at the Center of Excellence. Thank you for muting. That's much better. All right. We wanted to share with you our mission is to increase access to comprehensive, effective, and affirming healthcare services for trans and gender variant communities. And we do that in a number of ways. I think that Dr. Deutsch will go further into that when she begins her portion of the webinar. But you can see Dr. Deutsch there in the front on the right side of the screen. She's wearing glasses, and I'm on the other side with the red scarf, so in case you want to see what we look like. And I see Leanne. Hi, Leanne. So, now, I wanted to share with you this slide, which is just a representative of the many ways in which transgender people self-identify. You know, I think that it's important to understand that transgender as a word and as a concept is really, you know, a much more recent way for us to collectively identify. And that there are many indigenous ways in which trans people have self-referred to themselves and self-identified over time. I think that for those of you that are working with trans people, wherever you may be around the planet, that it's important to honor and respect the ways in which we have self-identified for years and ages. And so just keep in mind that transgender is, a relatively recent way in which we do so. I wanted to provide for you a little bit of background on why PrEP is such a welcome opportunity for us in terms of HIV. Hello? Can you hear me?
We can hear you.
Okay. Geez. Thank you. Okay. Anyway, this is the findings from a systematic review and meta-analysis that was published in The Lancet in 2013. And you could see there were 15 countries that were included in this meta-analysis, including the USA, 6 Asia-Pacific countries, 5 in Latin America, 3 in Europe, with a total N of over 11,000 transgender women. Overall prevalence was 19.1% pooled, and the odds ratio for being infected with HIV, and this is the data point that really strikes home for me and really is indicative of the burden of HIV disease among transgender women, was that across the countries, a trans woman was 49 times as likely to be living with HIV as other adults of reproductive age across the 15 countries. And importantly, they were less likely to have access to and utilization of HIV services. Okay. So here are some considerations for PrEP usage that I think that Dr. Deutsch will be addressing in her comments in a few minutes. Is PrEP, in fact, a viable option for trans women? Why are trans women enrolled in PrEP demonstration projects not retained in the research? It's very clear from the literature that when trans women have been enrolled in PrEP demonstration projects, that they have not actually been retained to the degree that other populations have been retained. And why are trans women included in MSM demonstration projects? I think that is, one of the confounders for those of us that are working specifically with transgender individuals is we really feel that it's important to separate out the populations. I think that another consideration is that we've seen that all women, including trans women and non-trans women, have been underrepresented in the demonstration projects, and I think that is something that really concerns us as well. And we are interested in knowing what, in fact, are the cross-sex hormone interactions to consider, and what will the long-term impact be of the PrEP uptake along with the cross-sex hormones. Are those things that we need to be monitoring, and how are we going to do that? I think that also when we're looking at PrEP uptake around the globe, we need to be considering who is paying for PrEP. So, PrEP is pre-exposure prophylaxis, and that means that, of course, in order to participate in PrEP, you are HIV negative. So many people around the planet who are not HIV positive don't have access to healthcare services. So who is going to pay for PrEP, and then who is going to be doing the monitoring? I think another thing that we need to be considering is that IPREX, which is one of the studies that was really responsible for many of the original claims for efficacy showed there was an early sub-analysis of data that was revealed that there was no specific evidence of PrEP among trans women enrolled in IPREX. And IPREX investigators have speculated this was likely due to barriers to adherence among trans women in the study. Also, community awareness of PrEP, we conducted 2 series of a total of 5 focus groups of HIV-negative trans women in San Francisco to explore their knowledge, beliefs, and attitudes towards PrEP as a prevention tool. One group was conducted in Spanish. We conducted 4 in English. We had a total N of 49. And this is what we found among this group of 49 trans women who live in a city in the United States that has high access to medical care. And all of the trans women who participated in these focus groups were in fact connected to treatment of some sort or another. They all had access to health systems. And surprisingly, this is what we found. So no participants report having taken PrEP or having been offered PrEP by a provider. The vast majority of participants had never heard of PrEP. Levels of interest in PrEP as a potential prevention tool were mixed, with most frequently voiced concerns about safety, side effects, and cost. Participants, and this is, I think, one of the major barriers for PrEP uptake, is that participants expressed high levels of medical mistrust. And hormones, as those of us that work with trans people know, hormones are the most important medical priority for many trans women. So I want to share with you just one quote from a focus group participant demonstrating medical mistrust. So most providers, this is from a focus group participant in San Francisco. So most providers see us as gay men, and most don't understand that we are women, and most don't treat us as such. So I have gone to a PrEP clinic in San Francisco before for testing, and I felt completely uncomfortable because I was the only trans woman sitting there, and yet they see me as just another guy. It's like, it's not fair. Everyone has the right to the same health care. I think that quote really is indicative of how many of how trans women feel in these settings and what keeps us from being engaged with the demonstration projects. So what are some of the facilitators? Competent, sensitive, culturally competent, and aware providers serve as a strong link to the community. Structural interventions, including job training, housing, diversion programs, behavioral health services, and we feel that more research is needed on cross-sex hormone therapy and antiretroviral drug interactions. And so with that, I'm turning the webinar over to my colleague, Dr. Maddie Deutsch, who will take over. Maddie?
Hi, thank you. So Carlos, can you share my screen and I can begin my slides? Share my screen, yes. Okay.
Did you get the message, Maddie? You can open your, right?
Let me see something here. Can you send me the share invite again? It didn't seem to work.
Silenciado. Sonido reactivado.
Send me the share screen because I tried to click on it. It was grayed out. Hello?
Maddie, if you are the presenter, you can share your screen yourself.
I don't have, okay, here we go. Okay, great. All right, great. Can you see my screen now?
Yeah, we can.
Okay, great.
Great.
Sorry about that. Great. So thank you, JoAnne, for the introduction. And I'm so glad to be part of this program. And it's always a pleasure to work with our colleagues in Lima on projects. And I'm so glad there's so much interest in this topic. I know we had some technical difficulties, so we're a little short on time. I'll move a little quickly through this and hope to leave a few moments at the end for questions. So just very briefly, I'm an MD. I practice at UCSF, where I have a transgender-oriented primary care practice at UCSF, and I also practice at the San Francisco Department of Public Health in our LGBT and primarily trans-only youth clinic, which is called Dimensions. So let's just start with a very basic background of what PrEP is. It's HIV pre-exposure prophylaxis. The study that's most relevant to our work is an intention to treat 44% risk reduction in HIV was seen in the PrEP study of mostly MSM and some transgender women who were in the initial analysis, and in that 44% risk reduction were aggregated MSM and transgender women together. So PrEP is a daily single pill combination of tenofovir and emtricitabine, which is known as Truvada in the US. And it's a common backbone for either 3-drug or 4-drug HIV treatment regimens. So most HIV treatment regimens include, well, many include Truvada plus 1 or 2 other additional medications. So it's a component of commonly used HIV treatment regimens. And it is also, in the US, Truvada is a component of what is referred to as NPEP, which is non-occupational post-exposure prophylaxis. So this is for cases not, when we say non-exposure, we mean not a healthcare worker who's been stabbed with a needle, but for someone who's been exposed to HIV generally through sexual contact. Truvada in the US is used in combination with a 3rd medication for post-exposure prophylaxis, though some PEP regimens elsewhere outside of the US still include just the 2 drugs. So what are the indications for using PrEP? Well, speaking broadly, condomless, any history of condomless anal sex, more than 4 to 6 male partners in the last 6 months, commercial sex work or exchange sex, or sex while intoxicated or using drugs. However, it's important to remember that especially trans patients who are already so marginalized, they may not feel comfortable disclosing some of their risk factors to their providers. So many of us are now starting to say that an interest in PrEP on the part of a trans woman really should be enough to consider her a candidate because of this concern of self-disclosure. How do we dose PrEP? Well, it's the once daily dosing of Truvada, as I mentioned. How do we know it works? When does PrEP become effective? When are you safe using PrEP? Well, PrEP becomes protective for anal sex after 7 days of daily dosing, but it does not become protective for vaginal sex in non-transgender women for 21 days. And so that's actually important in this context because when we're thinking about PrEP use in transgender men who may be having receptive vaginal sex, which they may also refer to as frontal sex. And this is actually from a study where they found, so if you look at these, at this screen, and you can see the dark bars are concentrations in rectal tissue, whereas the gray bars are concentrations in vaginal tissue, and this is the concentration after just a single dose of Truvada. So you might want to ignore these later concentrations because things probably become non-linear. But what's most important is you look on day 1, there's about 100, between 100 and 1,000 times increase the concentration of Truvada in anal tissue compared to vaginal tissue. And the reason for this is because PrEP is administered orally. So in addition to being delivered by the blood to the rectal tissue, there's also direct delivery of Truvada that is not absorbed and winds up in the anal mucosa. Whereas for vaginal mucosa, the only way for it to get there is through blood, and so that results in these lower concentrations and has resulted in the recommendation that 21 days of continuous PrEP be taken before you consider it to be protective. So this is just a summary of the adherence trials that have been done. These are so basically your intention to treat trials where they basically give people, what that means is they give people PrEP and then they see who's actually taking it based on blood levels, or they see rates of HIV conversion. And so as you can see, so this is not looking at people who, only the people who are taking it every day. This is looking at real-world use of PrEP, where we're taking into consideration whether or not people are actually taking the drug. So you can see iPrex did have this 44% reduction in rate, and then other studies have kind of been all over the place, particularly the studies in women. Non-transgender women in Africa are basically finding no effectiveness, no efficacy, because people are not taking the medication. So this starts to say to me that there's something about MSM who maybe are taking this medication, whereas when we're looking non-MSM communities, there may be other issues. People are not taking the PrEP medicine. And so that starts to raise a question, are we marketing properly to our non-MSM target communities? Because it looks like it's an adherence issue. So maybe we're not marketing PrEP in an effective way to non-MSM, or maybe there's a community level awareness of PrEP among the MSM community that has not penetrated to other communities. And there may also be issues of empowerment and self-efficacy and feeling like you have the ability to take control of your sexual health and of HIV prevention. And MSM may feel that they have more agency to do so than, for example, the heterosexual women who've been studied, or the trans women who've been looked at to some degree in some of these studies. So as JoAnne mentioned, we've conducted a subgroup analysis of the iPrex trial for transgender women. We had a very difficult time identifying the transgender women in iPrex, and I'll talk to you in a little bit about why. And the paper is currently under review, so it has not been published yet, so the data is not, really official yet. But as JoAnne mentioned, when we did identify the transgender women in iPrex, there was no efficacy on an intention to treat basis in preventing HIV. However, this is a graph from our in-review manuscript of PrEP in transgender women, and what this shows is the effectiveness. So this is on the as-treated basis. So what this means is we're not just giving people medicine and then we're seeing if they're taking the drug and seeing if it's preventing HIV. This is in the subgroup of people who, every time we checked their blood levels, they had blood levels present, and we mapped it. So what we found out was your hazard ratio of getting HIV approaches 0 as your blood level on random testing approaches about 700 femtomoles per punch on a dry blood spot punch. So what that means, the long story short for this graph, is that if you are taking PrEP, and this 700 corresponds to about 4 pills a week, if you are taking PrEP 4 or more times a week, you are almost 100% protected from contracting HIV. So where PrEP fails is when it's not taken. And when PrEP is taken, it is protected. And if you look at this here, this is the trans women are the maroon bar, and the MSM are the blue bar. These are the 95% confidence intervals, and they're wide because we had so few trans women in the study. But ignoring the confidence intervals, the two curves are almost the same. And so what this begins to argue is that there's no difference in the pharmacokinetics of the drug among trans women and MSM. So basically, if you're taking PrEP, it's going to work. What about the adverse events associated with PrEP and risks associated with PrEP? Well, there aren't many. So if you look over here at, these are all the adverse events that were encountered in the Adherence trial. So first of all, most of these p-values between the intervention group and the control group did not reach statistical significance. The only ones that did reach statistical significance were unintended weight loss and nausea, and the difference was, you know, in the number of events was, you know, maybe noteworthy. Some of these other things that just missed significance, elevated creatinine, headache, and depression, you know, maybe. But if you actually look at the numbers, the elevation in creatinine was statistically significant, but as a clinical physician, I don't know that I would care about that elevation. I don't know how clinically significant that statistically significant difference is. The other, you know, bone fracture is a difficult outcome to measure in a short trial. You know, that's something that you probably would see after years. So I don't know that this lack of difference in bone fracture is really reassuring. The concern is the effect on bone density of this medication. However, when they looked at bone density, the actual bone density, the difference was statistically significant, but the clinical significance, again, was very limited, if any. So basically, with the exception of maybe some nausea, headache, maybe some mood issues, many of which tend to resolve soon after beginning the medication, which reminds us to provide, you know, kind of support for patients who are beginning PrEP and to help them understand how to handle these symptoms and that maybe they're going to go away. There really aren't any significant adverse events that we're encountering. And if you look, any adverse event or any serious adverse event, any grade 3 or 4 event, all of these p-values, there was no difference at all between the intervention group and the control group. So now I want to talk a little bit about how we can provide PrEP in a way that makes transgender women comfortable with it and want to take it. So I just like to put this up here to remind us about Dr. Sebelius, who's our colleague at the Center of Excellence, her framework for gender affirmation, which is really the only model that's been proposed to this date on the interaction between risk and gender affirmation. And you know, the long and short of this model is that transgender women encounter stigma, and they are oppressed. They have a lot of psychological distress because of all of the issues that trans women deal with. They have limited access to gender affirmation, but they need that gender affirmation in order to resolve these issues, which results in an identity threat, which leads to high-risk behavior in order to affirm gender. So when we understand this model, we understand how gender affirmation is a fantastic way to intervene at this construct within this model that allows us to develop interventions at this level. So I want to talk about value-added bundling, because now we're talking about how can we affirm someone's gender while giving them PrEP at the same time. So this is the concept of synergism, where the value of two items is greater, the sum of the two is greater than the individual. So you take A and you take B and you add them together and you have a greater value than A plus B. And the cost may be less as well if you look at it over the long term. So there are models for bundling service in HIV care that exist before, as well as HIV prevention. So you provide a desired service, which in the case of trans women would be hormone therapy. It's been looked at before in the care of HIV positive or at risk for HIV pregnant women who are very motivated to take care of their unborn child. However, they maybe are less interested or less likely to participate in HIV prevention activities or to go for HIV care for those who are HIV positive. So you have the person at the office for their prenatal visit, and you say, while you're here, can we talk about some HIV prevention? So transgender women may give HIV care or HIV prevention activities low priority. And there are a lot of different reasons for that. Some of that may involve prioritization of gender affirmation and hormones over all other, and people are saying, I can only go to so many doctors, I can only deal with so many pills, and the hormones are the most important to me. Transgender women may be afraid of interactions between hormones and antiretroviral medication. And transgender women may also prioritize gender-affirming care over HIV-related activities because, again, they're looking at ads on the bus shelter, they're looking at ads in magazines, they're looking at palm cards given out at nightclubs, and they're all MSM-oriented. And the transgender women are saying, I don't identify with these social marketing activities. Or they're showing up at physical spaces, at clinics, at programs, and they're looking around and saying, it's 95% MSM here, I don't feel like I belong here. So when we bundle HIV prevention and treatment activities with all of these things that trans women want, including a supportive environment, then we have the possibility to get to that A plus B, so A being the HIV-related activity, B being the gender-affirming activity or the desired gender-affirming related activity. We get that A plus B is greater than the sum of the parts. So how do we create a respectful and culturally appropriate care setting? Or why do we want to do this? Well, it improves all of these things, and this has actually been studied. Patients do better when they receive care in a culturally appropriate and respectful setting. So what is that kind of a setting? Well, creating gender-neutral bathrooms. What is your clinic or your program's bathroom policy? Are people able to use the bathroom that they choose? Do you have neutral bathrooms? Waiting room materials and atmosphere. You know, I worked at a service agency for a long time that had a big screen TV in the waiting room and basically showed MSM films and TV shows all day. And there was actually a few times where there was like some really soft-core MSM porn on, like fully clothed, but like men making out. And you know, one of my patients made a comment to me that that was really offensive to her, that, you know, she's sitting in this waiting room and she's having to, every time she comes, there's MSM films on. So we got some trans films on the TV that started to play as well, and we got some pamphlets and things in the waiting room that were trans-oriented. Electronic medical records, if you're using an electronic medical record, if you're not using EMR and using paper charts, do you have a way for listing the person's preferred pronoun, their preferred name, so that your office staff, your front desk staff can refer to the patient by their preferred name. If somebody's sitting in the waiting room and they go by Juana, but their legal name is Juan, and the front desk person says Juan, that person is probably going to leave the clinic and they're never going to come back, and you've lost your opportunity to intervene with them on whatever we're hoping to do. They also may be at risk. Maybe they're not visibly trans. Trans people are discriminated against and are subject to violence. Maybe they get called Juan, and then later they go into the bathroom and there's a homophobic, a transphobic, I should say, person. Then maybe they're going to go into the bathroom and assault that person, or follow them out into the street and assault them. So another thing I want to talk about talking to trans patients, this is for the service providers, is that trans people are diverse in many ways, and especially we're doing this international webinar. The concept of gender identity and the terminology associated with gender identity, once you're not speaking English and in North America, really starts to collapse from the North American European narrative. So transgender may not be the only word that people use to describe themselves, which relates to the initial slide that JoAnne had put up. You know, not all trans people want to talk about their gender transition or want to be told that they look good. You know, some transgender people appreciate getting feedback and saying, you know, you look great, you know, but a lot of transgender women, they just want to go about their business, and they don't want, when somebody finds out that they're trans or if they're visibly trans, they don't want a well-meaning person to say to them necessarily, oh, you did, you know, you look great. And trans people definitely are not trying to fool anyone, so transgender people do not want to be told things like, you could have fooled me, or I couldn't tell, or they did a great job on you, or you did a great job. It's really condescending, and it's just not really the appropriate way to talk to transgender people. So what do transgender people want? Getting back to that question of trans people coming for what they want versus what they might need. Well, they're looking for, in some cases, hormones. In some cases, surgery. Not all trans people want either of these things, but many do want hormones. And also, they sometimes need primary care. Transgender people get toenail fungus and high blood pressure, and they get ear infections. So hormones, when patients come to see you and they're looking for hormones, or if they're taking hormones, you know, they bought at the store, hormones have all of these effects on the secondary sex characteristics. We have plenty of data that shows that when transgender people are given hormones, it makes their lives better. So we know that hormone therapy is a good thing. It's a cheap intervention, and it improves all kinds of aspects of a transgender person's life. So these are unpublished preliminary data. These are not the final numbers because we have not finished collecting data, but this is an interim analysis in our Trans Women of Color SPINS initiative, which are 9 demonstration sites across the U.S. that are looking at HIV-positive transgender women of color and ways to improve linkage into and retention in HIV care. And we at UCSF are the Evaluation and Technical Assistance Center for this project. So this interim analysis found that when the hormone prescription came from the HIV provider as opposed to any other source, so unsupervised hormones, meaning they bought them themselves, or from another medical provider or some provider of some kind, people were more likely to be currently using antiretrovirals. They were much more likely to have access to HIV primary care in the last 6 months, and quite likely, more likely to have a self-reported undetectable viral load. This is not lab verified. This is a self-report baseline survey of patients who are brought into the study. So there's a lot, you know, it's preliminary data, it's self-reported, it's cross-sectional, and there are some limitations and possible confounders, but it is, again, supportive and suggestive of this concept that when transgender people are receiving HIV-related services in the same place that they're receiving gender affirmation, that they're going to have improved participation in that HIV activity. So let's talk about some of the challenges moving forward for engaging transgender people and transgender women in PrEP. So this was a study of acceptability and likelihood to use PrEP among MSM and trans women in Chiang Mai, Thailand. Only 37% of trans women were very likely to take PrEP on assessment, so we still have work to do in getting the word out about PrEP. The MSM in this study were about similar. There was no statistically significant difference. They also had similar rates of very likely. So there's also work to do in the MSM community in this particular geographical area. But again, reminding us we do have there's a huge area for improvement. And the only real predictor in the study of likelihood to take PrEP is being previously aware of PrEP. And that was a significant adjusted odds ratio of 3.3. So again, getting the word out and making people aware of PrEP is the strongest predictor of whether or not somebody is actually going to take PrEP among transgender women. So this is just here for demonstration showing, this is from a paper on inclusion of trans women in PrEP trials, and as you can see, there basically hasn't been any. So, you know, this is really, this number here for IPREX actually wound up going up quite a bit when we did our sub-analysis, and we went into the data very deep and identified a lot of people who would identify as trans by other criteria, even though they didn't check the trans box, like they checked that they identify as women, or they're using feminizing hormones. So it was very difficult and took a long time for us to put that cohort together, but there were more. There were about 300 trans women in IPREX, but still, everybody else, there's no trans women that we know of enrolled. And I'm going to come back to that with my last slide as we wrap up here in just a moment. So we have not studied the interactions between PrEP and gender-affirming hormones, but there are no interactions with oral contraceptives. We don't know how this translates to gender-affirming hormones. The biggest concern would be that the PrEP would have an impact on the hormone level, and that might lead to some hormone-related symptoms like hot flashes or migraines, and then that might motivate the trans woman to say, since I started taking PrEP, I'm having all of these hormone-related symptoms, I'm going to stop taking the PrEP, because again, there's that priority of gender affirmation. There's been some recent data in non-transgender women that the use of progesterone may put them at increased risk for HIV or may have some effect, but the thing that is believed to be is believed to have an effect at the level of the vaginal mucosa, which even for transgender women who've had vaginoplasty, they do not have a vaginal mucosa, they have a skin-lined vagina. It's probably not significant, but there really has not been much study, but there's no evidence to support that hormones have a negative effect on PrEP. The biggest question would be, is there an effect of PrEP on hormones? So the last piece now, what I want to talk about is, if you remember, I showed you all of those trials and there were no transgender women in them, and it's probably correct that there were no transgender women in them just based on the geography of where they were doing the studies and the demographic they targeted. However, the problem is if we're not collecting gender identity in a systematic way, then we're not going to know who the trans women are in our studies. So as you can see, I'm going to go back here quickly, initial IPREX analysis revealed that there were only 29 people who said that they were transgender, but the choices in IPREX it was not asked in a systematic way, gender identity. So 29 at face, but when we went into the data and dug around, there were really more than 300 people who had some criteria that would make them trans. So we recommend the two-step method, which is asking gender identity and giving any one of a number of identity options. In the US, these are the rec options that we use. Local other countries and languages and cultures may want to develop their own set of gender identities. And then you ask the sex assigned at birth on the original birth certificate. When these two are not aligned up with each other, then you have somebody who is on the trans spectrum in some capacity. And it is important to remember that there are people who, from a Western, Northern Hemisphere perspective, would be trans. And there are people who deal with issues that trans people face, meaning that they have a feminine presentation, they're maybe perceived as female, they're taking feminizing hormones. However, in some cultures, there's no terminology for that, so they still may identify as male because they don't even know that they have the ability to say that they are not male. They may identify in Spanish language cultures as gay, but they're still dealing with the reality of being a trans person from the perspective of how the world interacts with them. We have just another couple of minutes, and I'm going to just finish up right now. This was a study that was done of this two-step method versus the one-step. So one step would be, are you male, female, or transgender? The problem is if somebody says, well, I'm both male or I'm both female and transgender, I don't know which box to check. So there was at San Francisco State University, they took 2 freshman psychology classes that were arguably equal for all other intents. And they asked one class, are you male, female, or trans? And 0.84% said yes. They asked another class, what is your gender identity and what is your birth sex? And 1.65% of the class had a difference between gender identity and birth sex. So this demonstrates in this particular study highly significant difference between the groups, p-value of highly significant, that when you ask a two-step question, you're going to identify, in this case, twice as many transgender people. So to finish up, our questions to ponder for the way forward: what are ways to bundle gender affirmation with PrEP delivery? How can we raise community awareness of PrEP? Are we thinking at all about PrEP and transgender men? What about thinking about the interactions between PrEP and non-occupational PEP exposure? So people who are kind of going on and off between the two, maybe somebody comes in, they're looking to start PrEP, but they actually in the last 72 hours have had an exposure. So you would first consider putting them on a PEP regimen and then transition them to PrEP in the future. What about thinking about episodic PrEP in the future? This is being studied. Can people take PrEP, how many days of, can you just start taking it on Monday because you know this weekend you're going to engage in sex work so you can pay your rent. That has not been studied yet, and then the interactions with the gender-affirming hormones. This is our website at UCSF where we have protocols and a whole range of services and activities available. I'll leave this up here. I think we probably have time for just a couple of questions. I know I have to leave right after 8 o'clock myself, unfortunately. I'm sorry we had these technical issues when we started, but I thank you for your interest and attention, and thank you, Carlos, and Pedro, for arranging the webinar. Thank you.
Thank you so much, Maddie and JoAnne. And we have a couple of minutes for questions. Definitely, I included your bios in the chat so people have been able to read it. I also stated that we have recorded this session and it's going to be distributed among those who registered and posted on our website. Anyway, there was one comment from Sindra about the issue of PrEP only showing effectiveness among men in Africa, and in fact, apparently there's more evidence for effectiveness among women as long as they were adherent. The problem was, in fact, low adherence. But I mean, it's not central to our conversation today. I had a couple of questions, and I hope there will be time for. And Julie has also made that question. So, in essence, the idea is what are the main misconceptions about PrEP that seem still prevalent among trans women? And then, what would be the role of PrEP, of HIV PrEP in trans women healthcare? Or the different way of stating the same question, would PrEP be an important component of HIV combination prevention for trans women? Finally, Julie was asking what could be done to recommend, or what could be recommended to convince or to talk to researchers in terms of the need for trans women in PrEP studies. No? And I would add how to deal with policymakers and the consideration of PrEP as well. Okay.
So I'll try to answer those very quickly. So the first question, the misconceptions about PrEP, I think trans women are concerned about interactions with hormones and concerned about other biomedical risks, which I think a lot of people would have concerns about. People still have memories of the old protease inhibitor days with all kinds of side effects and facial wasting and regardless. Usually, the problem-causing medication in HIV treatment regimens is the third medication. It's not the Truvada backbone. So it's important to remind patients that the side effects that they may be aware of associated with antiretrovirals, are not generally associated with Truvada. There's a stigma associated with it as well, where if people know that you're taking PrEP, then they may, stigmatize you as a whore, or there's stigma associated with it, and so there's that non-biomed, kind of like psychological. As far as is PrEP appropriate, should it be an important component of combination prevention interventions? Well, yes, because we know when transgender women take PrEP, they don't get HIV, or we don't. I mean, we feel very confident that when taken properly, PrEP is very effective at preventing HIV. But the real trick is getting people to take the medication and to adhere to it properly. And we still have not done enough research on the ways to engage transgender women in using PrEP in ways that it will be effective. And we have to make sure that there's not false senses of security. We have to make sure that people are taking it, if they're not taking it enough and then they have a seroconversion because they're subtherapeutic and then they don't come back in for the periodic monitoring needed They could develop resistance to Truvada. So those are the considerations. And the last question, how can we convince researchers?
Maddie?
Yes.
Yeah, sorry. Could I just add one point to
Sure.
Considerations for trans women? I think that in addition to all of the things that you pointed out, I think that the other item to consider is that we need to really think about structural interventions in combination with PrEP usage. And, for so many trans women who are really struggling with day-to-day life because of lack of opportunities for employment, lack of housing, lack of education, all of these structural factors need to be built into any kind of combination prevention effort in order for PrEP to really be a viable option. Those are priorities for many of us, and without addressing those, I don't think that PrEP will be effective or, can be as effective as it could be.
I agree with you 100%, JoAnne. Thank you for adding that. And the last question, what would I recommend to convince researchers that trans women should be a part of PrEP demonstration projects for women rather than MSM? So I'll respond to this. I'd be interested in hearing JoAnne's comments after I respond. I don't know that I think that trans women should be part of, I'm assuming when you say for women, you're meaning non-transgender women or cisgender women. I think that trans women should have our own PrEP interventions because transgender women and non-transgender women also have different issues. And we're thinking about interpersonal level action here. So we're thinking about diffusion of innovations in the community and using social marketing, the prior knowledge being a strong predictor of future use, so getting the word out in that social network. So, I think when people are going to group activities, that group HIV prevention activities or group visits that are associated with a PrEP intervention, they're going to want to show up at a group and see people that are like them and people that they can relate to. And so my personal opinion is that trans women should have our own HIV prevention activities, including PrEP projects, and should not be bundled in either with non-transgender women or with MSM.
Yeah, I would agree with you as well, Maddie. I 100% agree, and I think that sometimes because of due to economies of scale, I think that that can be difficult in some settings where there may be a smaller population of trans women, and so I do feel that it's important for trans women to have our own specific interventions that are designed for and really from the ground have been built for trans women and the prioritized needs. I also think that if there is going to be any kind of merging of programming, that the programmers have a responsibility to to include trans women in the design of those services and in the implementation of those services. So when it's not possible to have standalone programs, I think that then we should be thinking about, are trans people involved in leadership at that organization? Are they involved in development of the services that are going to be available for trans people? Not just service delivery, but really involved in day-to-day aspects of implementation and delivery of those services. And I think that that is where we get bogged down. Sometimes, certainly has been the case in MSM serving organizations where programs may be inclusive of trans women, but not designed for, not designed for trans women, and certainly not inclusive of trans women leadership at those organizations. So I think that those are things that we need to be thinking about. Whenever possible, like I think we both said, specific in HIV prevention programs for trans women themselves. If there's an economy of scale issue, then include us in the management and implementation.
Well, I think our time is over, but I think it has been an extremely useful approach. Really, I think one of the first. I think this is the first for me. The first time I listened to a specific presentation on trans issues around PrEP, and this is definitely, particularly in areas of the world where trans women are the most affected population. The population with highest HIV incidence. I mean, really, we need more strategies, and we need to strengthen combination prevention approaches, where definitely structural interventions are essential. I can't conceive of combination prevention without a structural component, but definitely there we have to increase our option for specific, biomedical and behavioral tools as well. So I included your bio notes in the chat, so we will come up. Definitely, thanks so much, JoAnne and Maddie, for this excellent overview and for raising many questions. I hope in your own studies, I know you're starting important studies, and other people can also conduct studies. These questions will continue to be addressed. So again, apologies for the initial technical difficulties, but you completed the program, you two, and we will distribute it as soon as the recording is the video recording is ready, and we'll upload it to our website as well. So JoAnne and Maddie, thanks a lot. Okay.
Thank you, Carlos, for having us.
And thank you all for your participation. Bye bye.
Thank you.
Bye.
Bye bye.